in our housekeeping. For everyone joining us, we're going to give everyone about 4 more minutes to get logged on, and then we'll get started. While we wait, maybe people can put the temperature it is outside wherever you are in the chat. Our colleagues and I were just having that conversation and be curious what everybody's temperature is. Can you see the chat that I submitted? Okay. Medium rare. We'll give everyone about 2 more minutes to see if we get anyone else to get on with us. Is anyone doing anything fun for the holiday weekend? All right, we're going to get started. Hello, everyone. Welcome to the Crisis Residential Association's webinar. My name is Caitlin Keppel, and I will be serving as your host today. We have a few housekeeping items to go over. The Zoom platform allows you to submit questions through the Q&A portal or send chats to the host or presenters. Everyone will be muted for the webinar. Questions will be answered throughout the webinar. Please submit your questions through the Q&A portal located in the controls of your Zoom app or website. Today's webinar will be recorded. Recordings are available for all members of the Crisis Residential Association through our website portal. If you're interested in becoming a member, visit www.crisisresidentialassociation.org and click on Become a Member. You will receive a survey via email at the conclusion of this webinar. We appreciate your feedback as it helps to inform future webinar offerings. The Crisis Residential Association is a 501c3 nonprofit organization. We exist to support the operational and clinical functions of crisis residential programs around the world. Rooted in the values of empathy, recovery, and continuous improvement, the association seeks to connect providers with the best ideas and behavioral health treatment to transform the way people receive mental health care. You can learn more about us on our website. Both registration and the call for presentations for CrisisCon 25 are now open. We're looking to have more crisis residential focused presentation at this year's conference, so please consider submitting. The conference takes place September 28th through October 1st in Indianapolis, Indiana. The call for presentations closes on May 31st. Check the CrisisCon website for the latest conference updates at www.crisiscon.org. You can also follow us on social media and join the conversation about building better alternative to psychiatric hospitals. Now, I would like to introduce your host to you. Give me just a second. I'm going to pull up the PowerPoint. All right. So we have Himali Pandya. She is with us. I'm sorry. Let me fix this slide.
Hello, how are you? I'm the Chief Strategy and Development Officer at People USA, so happy to be here. I'm also joined by my colleague, who I'll let introduce herself.
Hi, good afternoon, everyone. My name is Kimberly Wang. I'm the Chief Operating Officer at People USA. Happy to be here with you all.
So I'm going to tell you all a little bit more about Himali Pandya. Himali Pandya is a mission-driven executive with over 15 years of experience leading high-impact initiatives across behavioral health, social services, and human services sectors. Himali currently serves as Chief Strategy and Development Officer at People USA, where she has driven organizational growth, expanded revenue, and strengthened external partnerships across New York and beyond. She successfully led the creation and execution of People USA's organizational strategic plan and continues to guide its implementation. Himali is known for building inclusive, outcomes-driven programs and leading cross-functional teams through thoughtful strategic growth. We have Kimberly Wing. Kim Wing is a licensed clinical social worker who has worked with not-for-profit organizations in New York State and New York City for over a decade. She received her master's in social work from Silberman School of Social Work at Hunter College. Prior to coming to People USA, she worked for Goddard Riverside Community Center as the Associate Executive Director of Permanent and Transitional Housing Services. Kimberly has experience working with severe and persistent mental illness, chronic homelessness, chemical dependence, co-occurring disorders, domestic violence, and the aging population. All right, I'm going to turn it over to you, ladies.
Thank you so much. Appreciate that. And we're honored and thrilled to be with you today. Would you hit the next slide, please?
Hi, everyone. Again, Kimberly Wang. So happy to be here with you all. Himali and I both work for People USA, which is a peer-led behavioral health organization. And we have crisis residents, which we have our respite programs, which we call our Rose Houses. But we also have a wide variety of other complementary supports for the people that we serve. Just a brief overview of some of the things we do. We have our care coordination program, our housing programs, we have crisis stabilization, We have warm lines, which you see here, sorry, support lines. I forgot we changed that name recently. We have mobile teams, employment services, and we have peers that we embed into community settings such as clinics and hospitals. Overall, we want to make sure that we're really meeting people's needs at every point of their recovery journey. And so we've built a continuum of care within People USA in order to do that and to make sure people are having the best chance to have wellness, whichever way they define it for themselves. Next slide. So this video is going to show you a little bit more about what our respite, which we call Rose House, is. We can hit play.
You may need to enable the editing.
Give me just a second, you all. I apologize.
While we get this video up and running, if folks could write in the chat their role, I think that would be really helpful for us to know a little bit about who's in the room. So it could be your title, or it could be, direct service, clinical, admin, whatever you want to share. That'd be great if you could chat it. Nice. Great. We'll have plenty of opportunities to engage in the chat later on. So we appreciate your participation. We want this to be a conversation when we can. So thank you.
Today, in our country, if you look at the headlines or watch the news, you'll hear a lot of discussion about mental health and behavioral health issues. Very often, when someone is in a mental crisis, they are brought to what in the past was called a psych ward. Today, we call them hospital inpatient units. In the 1980s, many of the institutions that offered long-term mental health treatment were shut down. This has led to a shortfall in the services that need to be available to people in mental crisis. Hospital inpatient units across the United States and locally are understaffed and untrained to work with people who have behavioral health challenges. Often, people seeking help enter an environment that is cold, impersonal, and isolated. They end up there because there is nowhere else for them to receive the treatment and counseling they need. Many who enter the inpatient units are scared, confused, dealing with addiction issues, and even going through withdrawals. At times, they are angry because they do not want to be there. They are often grouped together with other patients with wide-ranging mental health needs. However, in most cases, they have nowhere else to turn to get assistance when dealing with depression, anxiety, suicidal thoughts, life stressors, extreme emotions, and hopelessness. There is often a lack of information given to the patient about their status while they're there, and there is rarely talk about recovery and hope. People USA has offered the Rose House as a viable alternative to many people seeking counseling and help over the years. Guests come to the Rose House and enter a safe and welcoming environment where each guest can stay up to 7 days to get assistance with their crisis, as well as get connected to the appropriate community services if needed. While staying at the Rose House, each guest receives compassionate care that is people-centered and void of additional trauma. Very often, family members receive counseling and advice to assist in their loved one's recovery. The respite is 100% voluntary, and each guest is educated on different options toward recovery, thus breaking the cycle of living a life in crisis. Many guests have utilized emergency room and inpatient hospital services repeatedly to address crises. And the Rose House is designed to stop the home to crisis to hospital routine.
Thanks. Next slide. So that video really gives you a good sense of what our Rose House model is for peer respites, and the way they look. I think that's an important piece. I think sometimes it can give you a lot of information when you visit a physical site and kind of see what it's like. Um, and and so the video talked a lot about the psychiatric inpatient ER piece, the diversion piece that the Rose House does. I also want to mention the criminal justice diversion. We have plenty of police drop-offs to the Rose House as well. It's a walk-in voluntary program. And so if a police officer drops someone off, as long as that person wants to come in, they are welcome in. We often will have police officers in the community engaging someone and sort of saying, this person really needs help. Handcuffs. And so they'll give us a call and say, I have somebody in the community, and we'll typically say, can we talk to them on the phone and really get a sense of, is this a voluntary thing? Is this something they want to do? Tell them a little bit about who we are and what we do. And more often than not, they come in and we're able to kind of get the police officers on the road doing their thing and really get the people that need the help to get the help. So if you could go to the next slide, please. And so this gives you a real sense of kind of the physical site. One of the things that's really important around our peer respites is that we lead with our values. We have sort of these pillars that are our foundation. We have our mission, of course, you all have missions in your organizations, but our values are what sort of keep us focused on what's most important. And every organization, I'm sure, comes up with their own kinds of core values. And if you work at an organization that doesn't, I highly recommend that you do, even if it's just in your department or in your program. But our organization believes in, honesty, compassion, innovation, community, equity, authenticity, courage, mutuality. That's that real peer support piece. Advocacy and of course peer support being so embedded in all of this as a peer run organization. You see here that the physical site looks like your home or mine. It's not a sterile setting. It's not like a clinical setting. It's really homey. We want people to feel really comfortable, like they're in a home of their own. Next slide, please. And so we really have these 4 pillars as the basis of all of our programs, but in particular, the Rose House peer respite model. And so, engagement is that sort of welcoming, respectful place, being really clear about here's what we do and here's what we don't do. We're not going to force you to be here. It's voluntary, and you get to decide how this goes, right? You're in the driver's seat of your own recovery. The environment you saw, it's a physical site that feels really comfortable, disarming, and the environment we always have like art supplies and music supplies and a variety of different things so people can kind of work on their wellness as they're working on their recovery. I see the question. Yes, the bedrooms are all private. We don't have shared space as shared bedroom. So each individual bedroom has one individual person, and we're talking about adults, individual adults. And then good question. And then the mutuality, we're peer run organization, peer led, peer staffed. And so, we are there to be the provider of hope. If we can do it, so can you. And we're going to walk alongside you to get that self-determined recovery to meet whatever goal it is that you want in life, to make sure you can thrive from a wellness perspective. And that's really our philosophy. That's that last piece, that we believe recovery is the expectation. We know that recovery is not a straight line. We know that it's not simple or straightforward at all. And we expect the complexities, and recognize that we believe recovery is just the expectation, and we're going to walk alongside you to get you to that, again, self-determined, self-identified recovery. Next slide.
So as Molly was sharing, we have our values and we want to make sure that we are operating within those values with everything that we do. But how do we do that? And so we've developed a way of doing that by utilizing the tool of data. We know that most people don't get into the human service world because they love numbers and they love data, but utilizing it as a tool to be the most with effective and within your values can be really meaningful and impactful. So we looked at, the measurements of wellness from our perspective compared to what's required in our contracts. And we saw a real difference. So our contracts were asking us around percentage of diagnoses and drug use, number of referrals made. They're asking us around if people are on medication, if they have had a follow-up, but they weren't asking anything around quality of life improvement. And we understand that demographics and, if someone received a referral and these types of questions are important, we're not saying they're not, and we have to meet the contract requirements. But we took the opportunity to say, how do we know we're staying within our values? How do we know that we're meeting our mission? How do we know that we're making impact and that what we're doing is working? So we decided to create our own key performance indicators, also known as KPIs. And some examples of what we did was we wanted to know, do people feel that they are improving from our services? And then are they satisfied with the service that they received? Are we reducing the use of the emergency room and the criminal justice system? To us, that's huge. It's one of the main purpose of why we exist is to have an option for people that meets the need where that need is. And so we're not saying that people don't need to go to the hospital, at times, but if they don't need to, we want to be the place where they can turn. And we also want to make sure that they get a quality service that makes them feel cared for. We want to know about service linkages and referrals because we want to know what is the system level work that we need to do in terms of the continuum of care. People USA values partnership with our communities, with our stakeholders, and we really need the data to tell us where there's gaps and what is our relationships that we need to continue to foster in order to meet the needs from a systems perspective. So we developed these KPIs and we created a data initiative. We invested time, money, resources to create this new way of thinking about how we measure what we do. We're still doing the required. We didn't throw those out. We have to do them. But when opportunities allow, we do try and ask funders if we can look at what's required and if we can switch more to our KPIs as opposed to what's being asked. Next slide, please. So we're going to ask you to be a little interactive with us, which I know is a little different when we're doing the chat, but this is something that we are tracking. So we're looking at what would have happened if the Rose House wasn't available. Where would people go? Would been arrested, emergency room? Would they have contacted mobile crisis? Maybe been on probation violation, stayed without support in crisis, or waited for a current provider? And we're curious, if you saw this data, what would you think about? What would come to your mind? How would you use it? Because we want data to not only be tracked, but then to inform practice or inform advocacy. So how would you use it? What would this inform you? And you could just put in the chat anything you would do with your team or what comes to mind for you if you saw this. Anyone? That we need places like the Rose House? Great. Others, if you saw that 46% of people would have stayed in crisis without support, 16% waited for a current provider, 25 would have gone to the emergency room, and 2% would have been on parole, probation violation, or been arrested. Does some people say, hey, I need some more information. I'm also seeing what comes to mind for me is that lots of people would just suffer alone. This is not a focus in our conversations about alternatives. Oftentimes the focus is diversion from hospitals or jails. Morgan, I really love that comment. At one point when we were talking about this KPI, someone said, why are we tracking that? Why don't we take that out? We're talking about diversion, right? And I said, we need to know, what if people, who are the people silently suffering that aren't going to the hospital because maybe they don't have someone watching out for them. Maybe they don't have the privilege to actually be able to get there or have someone with them, and or would not actually go to jail. There's people who are just suffering silently. I think that's a huge piece. Free peer support over the phone, warm lines, or the hospital is not helpful and traumatizing, right? So they've been there multiple times and they're not going to go again. Create reach out programs in the community. As a peer supporter, I would feel as though encounters at the ER can be traumatizing. Yeah, because of the improper triage. Yeah. Yeah, and that's what the Rose House is, right? We're trying to, the Rose House, the Crisis Stabilization Center, all of our continuum of care is creating the alternative that is hopeful, that makes people want to come back. And when we track how many times people are coming to us, we don't think that coming to us multiple times is an indicator of us not being successful. We think the opposite, because that means people feel good about the service we provided, hopefully. Next slide, please. Thank you all for your input there.
All right, we're going to try it again. You're running this program. This is the data that you see. The question that we've asked is, what would you recommend Rose House to a loved one? That's important. We want to know. That's a real indicator of satisfaction if they'd recommend it to someone they love, and you get 100% yes. What does that indicate to y'all? What would you do with this information? Thank my stash. Love it. Yeah, appreciation is in order. Sure. Anything else? Need to create more of these. Okay. Could say this is so great that we need more of these. Great. Because everybody's going to say my loved one is a referral. Service quality is being adhered to. Level of care and commitment is honored. Oh, great. Utilize peers in the treatment plan. That's definitely, we're peer run. Everybody who does any kind of planning in our organization is a peer. So they're involved in every step of the process. People will go back when needed, right? What Kim said earlier about, yeah, these folks will return. And that's a good thing because people are getting their needs met. Yeah, thank you so much for that. Agreed. Certainly this is where we want to be, right? We want to be perfect, 100%. I saw this, would be a little skeptical and would think, the kinds of programs we run, and any program at all, even though we're doing all of those things that we talked about around our environment, engagement, mutuality, philosophy, leading in our values, person-centered care, high customer service, all of that. I find it really hard to believe that 100% is where we're at. And I would really want to think about the data integrity or the QA, quality assurance piece of this to say, is this, so it's a trick question. I love it. A little bit of a trick. You got us. But I think you're all right though, right? Thank your staff. This is amazing. Wow. And I would think I got to look into this to make sure that this is the case because 100% feels unrealistic. And that's the other piece of data that's so important is when we're thinking about targets and measures, we want to be realistic. Everything is not going to be 100%, and that's okay. You know, we've got to come up with, is it 90? Is it 85? Is it 95? Whatever that percentage is that feels right for the group, or is it just increasing by 5% year over year, right? Whatever that looks like. And so this is a good reminder of being grateful for our staff. Thank you to our staff. And also worth a second glance. Sometimes the data, just because it shows up this way, doesn't mean there's not another story to uncover. I'm just going to read what Morgan said. I think is a really good point. A sign of psychological safety is that people feel safe expressing negative views. So I'd be curious about that. But also, I think people are comparing against really awful experiences. Agreed. I find that people are very grateful for basic empathy and respect. We see that every single day. Every single day in all of our programs, we see that. Thank you so much. Next slide.
So the next few slides are going to show you where we're currently at with our data. So as we said, we really want to make sure that we're using the data that we're collecting. We've put in a lot of time and effort into building the ability to collect data and to collect data that's meaningful, that tells us whether the impact we're trying to have, a person-centered, trauma-informed, hopeful recovery option, is there and being utilized. But we don't know unless we actually look at the data. So we've put a lot of effort into that. And the slides before this showed you the pie charts. Where we now are is we have live dashboards that we use every day. So this is an example of our Rose House data, and the bottom guest visits could be a little triggering as it looks almost like a hospital reading of vitals, but it tells you throughout the day, every day, how many people are at our Rose Houses, and how many unduplicated and how many total, comparing it to the other houses that we have in different counties. Our supervisors and managers are able to pull up these dashboards in real time in their team huddles that they have every morning and say, hey, like, what's going on here at this house? How many people do we have? Why is Warren, Washington lower, etc. Next slide. Another example that we have from our dashboard is looking at it this way. So we look at the number of service referrals for the month, for the year, and our house count for the month and year, week, etc. And on the top, you could see we can change it by house. So we can go to Dutchess, to Orange, to Putnam, and really look at it significantly. On the side, we want to see how many times have we had an incident lately where, you know, something happened and we had to maybe address it in a way that we need to look at from a quality assurance point of view. And we want to try and have those incidents far and few in between. And so we're tracking that to see from a quality assurance. And if it's, you know, 2 days, 5 days, then we know we have a challenge there. Next slide. And then this is my favorite one. I find this to be just the one I love to look at the most. So we have a 95% KPI target. So we want 95%. We think that seems more realistic, of people to say they feel better able to cope, we met their needs, and they would recommend us. And every day we're looking at this, and you can look at it throughout the different houses. And, you know, we have a threshold that shows us if we're meeting it or if we're below. And if we're finding that we're below, we want to dig into why. I think it's great if we're at 100%, but I also think it's great if we're not, because we can learn a lot from the people who are receiving our services and what we can do better. They know best, and we want to dig into that data and say, we're at 93% here. Why is that? Is it a system challenge? Is it something in our own Rose House? Is it something in their personal life? What's going on? And if it is system challenge or our own programming, we can think about an advocacy effort or a program operational change that we need to make. So we're really using the data to inform, to get back to our mission. And I think a big difference in thinking for us is that we're not collecting data to take people away from person-centered engagement. We're using data to inform how to best do that from the voices of the people that we serve. And, you know, on the side, you see the diversion data, state and crisis being one of the highest. Next slide. So I believe this is me, right, Himali? Yeah. How do we balance all this? So we have big jobs, right? I saw some of your titles and what you do. Everyone is very busy. So how do we balance the contracts, the funder, making sure that we are meeting with the people and seeing them and not just sitting behind a computer screen all day? How do we balance all of it? The balance of it is really important to make sure that leadership is bought into this initiative. Your leadership and your finances to fund it in a way that is sustainable is really important. And Himali's going to talk a little bit more about that. We also want to make sure that everyone is involved throughout. We need leadership buy-in, but it can't be a top-down approach where it's only leadership leading this. It needs to be across the agency from every employee, because it's a culture change and we know that culture takes the whole team. It doesn't take just a few people. We want to make things easy and not complicated. We want people to be with people, not behind the computer. So keeping questions simple, keeping the way we collect the data brief. We don't need 30 question surveys. We don't need 5-step answers. We need yes, no, and simple, brief. We want to develop best practices and look at it. The data integrity piece is so important. And um, it's really an understatement, I think, to say it's important. Making sure that we are not building the system to collect the data and moving forward using the data and missing the big meat of the sandwich, which is the data integrity, and looking at what are the system kinks? What are the educational pieces that people need to understand why we're asking this, or what's standing in the way? And we need to talk to staff in order to do that and to have them a part of the culture, and spend a lot of time working out those systems, working out those workflows, and developing those processes and procedures. Because if it's simple and easy, it's going to be done smoothly. If it's difficult, challenging, frustrating, there's going to be resistance. And we don't want people who are great employees came to an organization with a mission that relates to them leaving, because now we're trying to understand better how we can do what we do through KPIs, but we haven't made it work for them. So it's really important that we develop those best practices, processes to make the culture one that continues to stay at the heart of why people came to the work that they did and make it feasible. Next slide.
Right. And so I know some of you are probably funded by Medicaid, have a fee for service arrangement with Medicaid or some kind of insurance carrier. And that creates another complication in this, or just another piece. And we do it too. And I want to talk a little bit about sort of our journey of how we incorporated Medicaid into our program. And it's important that I said incorporate Medicaid into our program as opposed to some other order of operations. And the reason I say that is I know I've worked at previous organizations. We've worked with other organizations that take the Medicaid or the billing manual and then create a policies and procedures for the program based on that billing manual. And that doesn't work. That's not going to get you high quality service. That's not going to get you person-centered care. It's just not. And I think we all know that. And it'll maximize your billing, probably, maybe, but it's not going to keep your staff happy because they're coming to do this work to help people, not create more billing. It's not going to make the folks you serve happy because their billing is not what they care about. They want to get service and the support that they need. And ultimately, it's not going to be good for your bottom line because you won't be able to retain the staff and do the work that you need to do. And so it's really important to lead from a place of values and a place of mission. Start there to create the sort of policies and procedures for a program, and then allow to allow the Medicaid guidelines to be incorporated within that policies and procedures. And if it doesn't work, if it's sort of just two separate documents, then Medicaid funding for that program isn't right. And I think that's a tough thing to say, but it's important. And I recognize in this world of sustainability of all of these programs, it can be hard to say that, but it's the truth. We want programs that are good for the people we serve and good for the folks doing the serving, not just good for our bottom line. And so that's really important to kind of lead with our values here. So I'll tell you a little bit about how we did it with our Rose House. And so we have 4 Rose Houses that we operate in New York, and we've helped, oh gosh, 3-4 dozen open throughout the United States. So if you're looking to open a model similar to ours, we're happy to chat with you about how we did it, what we did. You know, we do lots of that throughout the country. So happy to do that. Our contact information is at the next slide. But what we did is we 30 some odd years ago, we our local psychiatric hospital was was closing down. And so there was a bunch of folks who were there for years and years. And there were some folks who would have gone there very, very shortly. And they gave a bunch of different organizations different pockets of money to help meet, treat, manage, support that particular population. So our organization opened a Rose House, opened this house that would allow folks to come in based in exactly what I said earlier, what we've been talking about, our continuum of care and our model. It looks just like that for the most part. And we had some, local funding for that, and it was going great. We really felt like we were helping people. The peer staff felt really empowered. I think there's a lot of talk about peers now. Certainly that wasn't always the case where peers had the same I'm going to use a tricky word, same respect as some of the other staff. And we see that now. We didn't always see that before. They were seen as this sort of siloed other kind of credential. And now we see that peer support is at the center of all of this work. And so we had peers who felt really empowered, felt really good, felt like they were able to help others heal in the way that they did. And we had folks coming in. Everybody's doing great, right? It's really working. And then we had our state Office of Mental Health of the state sort of look into like, hey, what's going on there? Because what we were producing is we saw that we were getting reducing the number of ER visits, and certainly we didn't have the inpatient psychiatric hospital anymore. And none of the surrounding areas near us were really none of our participants were really utilizing those services. They were utilizing us. We also saw that the criminal justice involvement really decreased, right? We saw that police officers, like we shared earlier, were sort of like able to go do what they need to do and really let us support the people that we need to support. And that allowed us to share the savings in the system. And I should say that's, if we're being honest, that's when the state was like, ooh, savings, what's that about, right? When we were talking about outcomes and people feeling good and people recovering, okay, great, that's nice. We'll keep funding you locally. But as soon as we said, oh, and there's some system savings, okay, now we're interested, says the state. And so they came in and sort of saw what we were all about and said, oh yeah, this is great. We need lots more of these, but it's not sustainable. Not every community in New York or anywhere really can afford this kind of a service, a program. And so they said, ooh, what if we could bill Medicaid for it? We said, if we can help you write the regs, we're happy to do that with you. And they took us up on it. And we wrote the regs in New York State based on our model. And it's really simple. It's if someone comes in or if they don't, and then it's one CPT code for those who do billing work. It's really, really, really simple. And it's based in this kind of work, in this values, mission-driven, person-centered, high-quality service care, where the individual coming in is the expert on themselves, and we trust them to be able to define their goals, and we really take that wellness perspective, and that's really in this model. And so we were able to really, in our small way, change the system to be able to kind of go from this Medicaid billing, very, what's the word? I'll just say Medicaid heavy, billing heavy model to a person-centered model in which we kind of really showed the savings. It's good for staff, it's good for the people we serve, it's good for our community. So that's kind of the story that we have around this particular program. We've done that a couple times over. And again, we're happy to share what we've learned from doing that in our communities and help you do it in yours. So Thank you, thank you, thank you for that. I just saw the really great work you're able to write the regs. Thank you, Morgan. I appreciate that. We're lucky. And you know that's not even fair. It's not even that we were lucky. I think that people really saw the value in the work we did. The data showed the value, and that's sort of the other piece of this, the power of data to communicate what we do and why we do it. Next slide. So I think we're going to pause here. Please feel free to ask us any questions in the chat if we want to talk a little bit more about this. Our contact information is here. I did see, Ginny, you were talking about Power BI and awards. And so if you want to talk about that stuff, we're happy to talk about that too. Kim, is there anything else I missed or anything you want to add before we open it up?
No, I say no and then I say yes. I don't know why I always do that. I think that one thing that we want to just highlight is data gives us a common language to talk to some people who may not necessarily understand the value the same way we do. So the numbers can't lie. So it's a really good investment if you have a strong feeling that what you're doing can change the system, can make change in people's lives. Investing in the data, I think, is such an important tool because people listen to the numbers. They don't listen to how we feel.
Open it up to questions. Or comments, or thoughts, or reactions, or disagreements.
Miles Stickle raised his hand. Miles, can you put your question in the chat?
Anyone who has questions can put it right in the chat. You don't need to raise hands, just type it right on in and we'll read them and answer them. Justin said, thanks for the peer recognition. Respect was a great term to describe our role. Thanks, Justin. As a peer-led organization, we couldn't agree more. So thanks for all the work you're doing.
Are you able to access Medicaid claims data in your evaluation? So we do have, I'm thinking Kim Psyche's data, right?
Yeah.
So we have access to it. Is that, I started talking and Kim, you probably have a better idea of this than I do. Is that the one that's delayed a little bit, or is that the one that we get in timely? There's like one system that's a little delayed and one that's more timely.
Yeah, Psyche's, I believe, is a little delayed, but
Okay.
we're not currently using it in terms of evaluating our outcome metrics. We're really sticking with the report from the individuals. So that might be a next step for us, but as of right now, it's not something we're actively utilizing on a consistent basis.
That's right, right. In terms of the data piece, our staff do utilize it in terms of like history of service and treatment. Yeah.
And to like advocate for someone to receive some of our services, such as like health home or housing, we will use it for that, but not necessarily to show the effectiveness. Can you
Can you
talk a
talk
little
a
bit
little bit
about,
about,
oh, you go. You go.
I'll read it, you answered, how's that? Can you
Okay.
talk a little bit about the infrastructure resources it took to build out these comprehensive dashboards and database? What were the main hurdles you faced when attempting to build out your data strategy? Great question.
Yeah. Um, I think so what we did was we really did an analysis of where we were at it with our data and saw how we were using it and why and what were the challenges maybe for the current staff or the system that we had. So the first step was really doing an assessment of where we were. And then we developed a vision of where we wanted to go. And our KPIs are ours, yours may look different. And I think that I should have said that earlier. You may really have a different set of indicators that you believe that will tell you if you're being successful. And we took a lot of time as a C-suite team and then as a leadership team and then across the agency to make sure that our KPIs were really aligned with our mission and vision and values. So that was really important. And then we realized we needed to invest some dollars in help. And if it was up to me, we would be able to invest a lot more dollars in the help, but we weren't there. So what we did was we hired a data manager who now is really more of like a data engineer and someone who's able to code and create dashboards and minimal coding. You don't need a high level of coding. But we have a EHR called Foothold Awards, and we thought that we could invest in an add-on there, but it really didn't produce what we wanted. So we needed someone who could help from the technical standpoint guide that. So we invested in that FTE. And then it became really clear that we needed to invest a lot of time and effort of the leadership team and the staff to train, coach, get buy-in. We created a data committee, which I have to say is the most fun data committee I've ever been on. This is the second time I'm doing this at an organization. The first time we had a data committee, and it was okay. This data committee is fun. I'm not gonna lie. And I think that's a huge piece around the culture. Like we play Jeopardy and we do escape rooms with data. We're having a data triathlon. Like we make it super fun, and our team seems to be competitive, so that works for us. We have prizes. But we realized we were trying to teach people in a way where they weren't hearing us, and we switched it. So I definitely think that getting everyone together, making the vision clear, investing money in someone who can support, build it out, and investing a lot of time and effort to build that culture is really important. And Ginny, I don't know what electronic health record you use, if any, and please reach out if you'd like to talk more about this. I'm happy to help guide you based on where you're currently at as well. Himali and I both.
One of the things, the data committee is amazing. It really is. I cannot like, it's like a sought after committee. And one of the things, it's just an interesting piece is, in the beginning, we're like, do we assign people? Do we not? Okay, let's see who's into it, right? Because we were afraid no one was going to join. Lots of people joined. One of the people joined was one of our executive assistants, and she's really into it. And she was not somebody that I thought was going to like jump on board. And it's been really fun to see different parts of the organization get really excited about data and feel empowered and comfortable. And so I just add that to the data committee is really neat. And I just think it's a really great way to get champions within the organization.
Yeah, thanks for that, Himali. Like sometimes we think like, oh, this person's in leadership, so they're going to want to do it, and this person's over here. But really, we don't know until we bring it across the whole organization. So I think that's a really great point. We have another comment. This is really great stuff. Our organization has been in the crisis residential game for 40 plus years. We are going through a transformation, and your presentation, sorry, I have to scroll down. Provided validation, we are headed in the right direction. Great. Congratulations on the transformation you're taking. And, like we said, we're here to help support if anything comes up. Data committee, wow. Yeah, it is a wow factor, gotta say. Any other questions or comments? You guys have been such a pleasure to be with today. And, we know data conversations can be dry. We hope this wasn't. We hope we got you excited to, dive deeper into what you're doing and how to make it a great tool for you and your teams and the people you serve.
Thank you. Thanks for your participation.
All right, well, if we don't have any more questions, then we can wrap up. Again, I just want to echo what our presenter said, and thank you all for coming to today's webinar, and stay on the lookout for our next one.
Have a great day.
Did we get a screenshot or should we do that now? Oh, you did.
Nice.
Thank you. You're amazing. Thank you. All right. Wonderful. This was great. Lovely group.
Thank you.
Is there anything else that you need from us or good to sign off?
We're good to sign off. Thank you all so much.
Thank
you.
you.
Yes,
Take care.
should be emailed to you.